ladies and gentlemen, and welcome to tonight's Wound Care Today Facebook Live. We're well aware how busy you guys are, so thank you so much for your time. Tonight's exciting session is called Portrait of a Patient, a new patient-centric way to learn about compression therapy. And our fantastic speakers, Dr. Christine Murphy and Maria Hughes, are with me now. Good evening, both. How are you?
Excellent, thank you.
Good, thanks, Ed.
Guys, thank you so much for joining. I'm well aware of the hard work you put into tonight. As you can see, ladies and gentlemen, they are doing tonight's session from home, home being Ottawa and North Wales. So if we have any technology problems, please bear with us, and I promise you'll get it sorted as soon as possible. The link for the certificate of attendance will be made available to you at the end of tonight's event. It's a global event, but for the UK listeners, that counts towards your revalidation. And a question that's frequently asked is all the slides and the event will be available on our website, which is woundcare-today.com within about 24 hours. So for you, but also your colleagues who aren't on Facebook. As our speakers will, I'm sure, agree, the more involved you are with tonight's event, the better. Please comment, let us know where you're watching from, but also ask any questions you want, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. As I said, it's an incredibly exciting evening. This is the launch of Portrait of a Patient, which is a global education platform empowering healthcare professionals to heal, but using patient stories. And our first patient tonight is Cynthia, who has a venous leg ulcer. I don't want to give too much away. I know our speakers don't want to give too much away. So to explore the new platform fully, please go to portraitofapatient.com, and we'll post this and we'll put links in and comments in so you know the link. So it's portraitofapatient.com to register, do the modules, but most importantly, please let us know what you think. Your feedback means the world to us, and what you say will help us guide what we do in the future. Before we start, a massive thank you to our global partners who are Solventum. Without your patience, your trust, your commitment to training and education, and your passion for compression, this event wouldn't happen and the platform wouldn't exist. So a massive thank you. You know who you are, from me and my team. Without further ado, it gives me great pleasure to introduce our first speaker tonight. Over to you, Maria.
Thanks, Ed. Hello, everybody. A very warm welcome to Facebook Live. I'm Maria Hughes. My previous role was Tissue Viability Lead in the community, but I'm now a nurse consultant in tissue viability at the Countess of Chester NHS Foundation Trust, and I'm a Queen's nurse. I'd also like to introduce Chris.
Yes, hello everybody. And just right now, I've got a nice big street cleaner going outside my window, so hopefully that's not too loud. So I'm Christine Murphy. I'm an advanced practice nurse at a hospital in Ottawa. Ottawa, as you no doubt know, is the capital of Canada. No, it's not snowing. It's 27 degrees here today. Beautiful day in Ottawa. And we have one of the largest vascular centers in Canada, and one of the largest training centers for vascular surgeons, in fact. And I work in a limb preservation clinic alongside vascular, looking after their wounds. I'm also an assistant professor at Western University in the Other London, which is in Ontario, Canada, teaching in the Masters of Clinical Science of Wound Healing program.
Thank you, Chris. So we shall plod on. So today we'll be introducing a portrait of a patient. This is a really new, exciting way of learning, and we'll be highlighting venous leg ulceration and how we address the concerns regarding compression therapy. It's a really different way of learning as opposed to what we're used to. So Portrait of a Patient also describes how compression therapy works and how a Coban 2 system provides guidance and tips to apply that correctly, which of course with any product is really essential. But please be assured that Portrait of Patient isn't just another simple application video. It's really something different. So you'll work through the module and you'll follow a patient called Cynthia through her treatment journey. And as we know, our real patients in clinical practice do have challenges that face them as they go through any treatments. And we will look at the concerns around compression therapy and look at the opinions of the use of the bandage from Cynthia herself. So our learning objectives this evening will understand the role of compression therapy, which is really important for any treatment that we introduce. We appreciate the challenge of compression bandages from both clinician and patient's perspective, which is also really important, because not just from the clinician applying the bandages, but it's so important to get the patient's view as well. We will recognise the commonly encountered factors that result in non-compliance, non-concordance, or non-adherence, whichever you choose to use in your clinical practice. We'll also understand that how 3M Coban 2, the two-layer system, really works, and how we can address any common concerns. Most importantly, we'll know how to apply Coban 2 system and appreciate how to have conversations about compression therapy with our patients about venous leg ulcers. And that sometimes can be quite challenging and address any concerns that the patient actually has. So about venous leg ulceration, well, it's globally getting bigger. Certainly as we know in our clinical practice, but often venous leg ulcers are the forgotten wound, and that historically we treated patients later as opposed to now we treat them sooner. It's really important that we look at our resources and how we manage things differently. And as we know, we're all strapped around the world with budgets and those constraints in our daily practice. But most importantly for me as a clinician, we need to make sure we're managing our patients' quality of life. And we're actually going to try and heal these wounds as opposed to manage them. So I guess, why are venous leg ulcers increasing? Well, there is the growing population globally, as we know. Our patients are living longer and obviously with multiple comorbidities as well. Our healthcare systems around the world are overwhelmed, as we know, but we really need to treat this underlying venous disease. Compression therapy has always been the gold standard of practice. We know that. Historically, we had multi-layered systems, and now we've moved to two-layer systems and other treatments that are available. Also, with our patients, it's about symptom management, thinking about odor, leakage, and pain, really important. And actually, how do we actually use this as clinicians, and how can we use this in clinical practice, delivering compression therapy in a number of ways? So we have bandages, we have hosiery, we have wraps, and I'm sure you've encountered many of these in your clinical practice. So this Facebook Live event will focus on compression bandaging specifically for this module, and the use of Coban 2 compression system. So with any system, it's really, really important that we undertake a vascular assessment. We need to know the vascular status of the limb. Sorry. That's really important for successful management. You need that diagnosis, and we need to rule out any arterial disease which may affect that blood flow, and we don't want to compromise the limb. You obviously have, due to your clinical areas, you'll have relevant policies and procedures which of course you need to adhere to, and link in with your relevant expert clinicians. So in people with arterial disease, compression can reduce the blood flow. If we have a compromised limb, so we need to make sure we're getting this right. We need to always obtain a Doppler assessment, undertake this, and acquire our ankle brachial pressure index, again working to your local guidelines and assessment. And Coban 2 compression system is indicated with people with venous leg ulcers with an ankle brachial pressure index of 0.8 or more. So what are our challenges with bandaging? So the use of compression therapy can be challenging in many ways for our clinician and our patients. Clinicians may be around their competency of application. Have they had enough training? Do they feel confident with the bandages and treatments that they're using? Do they feel confident they're going to actually start the therapy as soon as we should? Because historically we've waited this mysterious 6 weeks, which we no longer do, and we need to treat patients sooner. But our patient-related factors are also really, really important. So some of our patients actually talk about how bandages are itchy and slip down. In my clinical practice, I've had many a patient reapply compression themselves, telling me that the nurse actually undertook it, when I know actually the patient did do it themselves. Also, we need to make sure that patients be able to wear their footwear. Really, really important around quality of life. And so patients live their own lives and experience. So all these things are so important. And with compression bandaging and co-band too, we sort of need to meet in the middle. Really good quality of life for the patient, but obviously our aim goal is to actually manage and heal this wound.
So at this point, I'm going to jump in and introduce you to the portrait of a patient format and just give you a little glimpse into what this may look like if you dive deeper at the website. So the key idea here is to raise awareness of patient-centered care. As we all know, we know that compression is gold standard care. We know many patients have a hard time adhering to this compression, which is needed to heal their ulcers. And as Maria alluded to, these are sort of the orphan patients. When you think about other types of wounds, typically somebody's looking after those wounds. If it's a pressure injury, it may be plastic. If it's an arterial wound, it may be vascular. If it's diabetic foot, it may be the orthopedic surgeon. There is somebody that's looking into this as their area of care, their area of specialty, and publishing on it and supporting patients and developing documentation. But the venous leg ulcer patient tends to sort of go to the general practitioner and often has not great guidance on how that care plan is put together. So it's critical that when we do meet these patients that we can understand where they're coming from, what their barriers are, and why it is that they're having a hard time with their compression and getting their wounds to heal. So together, we listen with the patient and we look at those barriers and we try and break down those barriers so that we can get a program in place so that they can actually heal their wounds. So the portrait of a patient format uses animation and the journey is described in 5 parts. So the first part is an introduction to Cynthia as our patient and describes the challenges that she's had with her ulcers. The second explains the science and creates an understanding with the patient. Often, if you can describe what it is that compression is doing and what happens if you don't actually put compression on, explaining that this is treating the cause of the venous insufficiency and you need to treat the cause in order to heal the wound, you'll get patients buy-in. Very commonly, they don't fully understand the requirement for the compression. It's just something that's an extra burden on their day. Section 3 explores past challenges the patient may have and looks at the co-band 2 compression system as a solution. So why is it? Which barriers does this bring down? Section 4 demonstrates the actual application of compression, which is easy and intuitive when you know how. We put on lots of compression every day in our clinic, and it doesn't take any time at all once you get into a rhythm of it. And then finally, in section 5, we hear Cynthia's thoughts on what her experiences were with the compression and how this has helped. So, sorry. Now we're going to meet Cynthia. This is our patient. She's a 67-year-old female, and she's been suffering with this venous leg ulcer for 5 long years. And she's had very mixed results when she's tried to seek help before. She's had a negative previous experience with compression before. She has daily struggles with getting around, with managing drainage and odor, putting on her shoes. And also this is affecting her social circumstance. She's withdrawing socially. She's embarrassed about the wound. It's very unfortunate when you hear how this has severely impacted her wound. So we hear how open communication is desperately required in order to highlight these things that Cynthia is dealing with. If we just look at the wound and we don't understand all of her struggles and her barriers in her everyday life, then we're not going to be able to help her deal with these struggles. We highlight the benefits of compression, and we want Cynthia to understand that. So we're going to let Cynthia explain here.
Welcome, Cynthia. I'm the lead clinician in tissue viability here. What brings you in today? Well, it's my leg. It's swollen and sore all of the time and nothing makes it better. I've been living with this leg ulcer for years, but it's getting harder to cope with.
So we hear Cynthia is a typical venous leg ulcer patient that we may see in our practice every day. She's a female, she's over 65. She waits until life is intolerable with this ulcer to seek help because she's been trying to manage it herself with her everyday life. She suffers pain, discomfort, leakage, odor, embarrassment. And you can see her whole affect is one of overwhelm. Her expression, looking down, just her whole body language is saying that this is overwhelming to her. It's severely impacting her life. So with this format, portrait of a patient, the interactivity prompts questions that build a portrait of Cynthia's experience. And you can consider this in your own consultations. The prompts are for things like history, mental well-being, social life, and what compression experiences happened before. What has worked, what hasn't worked? Have there been slippages? Have there been issues with leakage and drainage and this kind of thing? Is she able to wear this in her everyday life? If she's working, is she still able to work? Or is it impacting even her income? So let's hear what Cynthia has to say.
It started 5 years ago when I was on a walk. I grazed my leg and it became itchy and inflamed. I put a sticky plaster on it, but it quickly developed into a small wound, so I went to the GP to get it checked out. They tried various dressings, but nothing worked, and it just got worse. And after some tests, I was told it was a venous leg ulcer.
So next, the clinician tries to explain the importance of compression. What is it? How does it work? How does it correct the vein problem, which causes the wound and keeps the wound going? Understanding the patient issues will help her adhere to her program. If she can understand how it works and why it's important, she's much more likely to tolerate certainly the beginning of compression, where many patients have pain at the beginning just because they have so much edema there that hasn't been mobilized yet. They know that's sort of an over the hump thing, and the compression is actually going to make them feel better and make their wounds smaller. Then they're much more likely to want to be on board. So patient-centered care with education and communication is critical if you want good results with compression. Next comes the science of compression.
Apologies. The science of compression is really important that we actually explain to the patient. And this in an innovative way, using the module, using a giraffe and a flamingo, which is really memorable as a student to actually apply this in clinical practice.
A giraffe's heart is a great distance from its feet. So, while its heart can pump out oxygenated blood at high pressure to reach all parts of the body, it needs to return the blood all the way from its feet back to the heart, against the pull of gravity.
So, following the science of compression, we return to the clinic and see how Cynthia's understanding is, what she's seen. Does she appreciate the role of compression therapy and how it plays in the healing of the wound? She'll always, of course, have some concerns, which is also really important that we address as clinicians. So some of the things Cynthia highlights is itching and discomfort. This is many times I've heard this in clinical practice. Itching of the skin, certainly large in the past multi-layered systems that have irritated the skin, and patient doesn't really want this directly on their skin. They also need to make sure that emollients are used and we cleanse our patient's skin appropriately. Also, tightness and difficulty in adapting. In my clinical practice, I have always sold compression to patients, if you like, by saying it's firm. If you do use the word tight, you get this negative connotations with the patient, and they often don't tend to actually tolerate the compression. Also, it's about mobility as well. Patients really struggle with their mobility with multi-layered systems. They can't wear their own footwear, and they suffer with mental health problems as they actually don't want to go out and see their family or attend social events. So it's really important that we encourage this with our patients, and the Coban 2 two-layer system, with it being low profile, can actually enable patients to actually wear the footwear. And all these positives we can reiterate to Cynthia as we actually explain what the compression is utilized for.
So the Coban 2 compression system that was suggested by the clinician on consultation with Cynthia has the benefits that it has breathable fabric. So this reduces the likelihood of itching and heat. There's no latex, so it's non-irritating, non-sensitizing. And it's, as Maria suggests, it's not tight, but it's firm. And you need this firmness, again, to mobilize that edema. So knowing all of this, Cynthia agrees to try. And the next part talks about the application. So the next stage of the module actually demonstrates correct application in a step-by-step format. You need to have the leg in a correct position. You need to see that the comfort layer goes on first, and then the compression layer goes on second, and these two sort of adhere to each other and form a nice firm compression. And this section addresses challenges with hints on how you can actually put this on in a comfortable way that people will tolerate. For example, dealing with skin folds. So they show a skin fold workaround where you can actually take folded pieces of the comfort foam layer and fold it with the foam side outwards to separate the folds out and make it nice and smooth so that you're not actually causing cutting and pinching and pressure areas. In my practice, it's easy and intuitive to apply compression and do things like protect the pretibial area from pressure, especially in very thin patients and so on. This system is very low profile. People can wear their normal shoe, which is very important to them because they don't want to go around looking medicalized in order to have their everyday life and not make this the center of everything they're doing. And they can retain the mobility, which is extremely important, just getting around the house, making, food, doing laundry, this kind of thing, and also supporting that calf muscle pump extra benefit that we need for that venous return. So it's straightforward in application. It's not tight, but it's effective. It prevents slippage, which is a common problem with other forms of compression, which keeps it in place and keeps it working. It conforms well to the individual because it's a wrap. It's not something that is sort of one size fits all. It's not made with latex, and it just helps keep them up with their normal lifestyle as much as possible. And we're going to see this on video.
Some key benefits include reduced slippage, easy application, and 7-day wear time, delivering effective compression therapy which has been shown to reduce chronic edema, reduce leg pain, and support the healing of venous leg ulcers.
I think Maria's going to
So
jump.
sorry. So the final part of the module revisits Cynthia and see how she's coped with the compression bandaging. So let's hear from her for one last time.
Therapy. And guess what? I can wear shoes again. No more bulky
I think we may have lost Cynthia.
It's a small thing, but it's made a big difference in my daily life.
Okay, so I think we've lost Cynthia, but please go to the module after this evening's portrait and have a look at the video and see what her views were. So I hope you've enjoyed finding out about Cynthia, this really new innovative way of looking at patients and how we manage compression. It's really great as a teaching aid for maybe our newly qualified staff or are new into any department. It's really easy to apply, and the actual module is actually quite fun and memorable with the giraffe and the flamingo. So the sessions also highlighted the benefits of the Coban 2 compression and how they can benefit both patients and clinicians alike. Really important. We need to make it effective for clinicians to use in our really busy lives that we lead as nurses and practitioners. But primarily we need to improve our patients' quality of life. We need to make sure they can wear the footwear, they can go out, they can feel confident, and actually ensure that the bandages don't slip down and they do stay in place, which the Coban does. So the patient should always be at the centre of our care, and that's everything that we do. And this is working in partnership with our patients. Sometimes patients have the whole historic views of compression rather than the low profile that we use today. So it's almost selling this to the patient, give them patient information leaflets. But for me, it's managing their pain. And always start the patient on full compression if their ABPI is appropriate to do so. As in my experience, anything else that's not appropriate, you'll never get the patient to full compression.
Thank you, guys. Just hugely appreciated. If you get a chance at the end of this, have a look at some of the comments, have a look at some of the questions coming through. It's absolutely fantastic. Guys, thank you so much for the questions that are now coming through now. As they both said, please explore this at portraitofapatient.com. This is the first of many. And as I said before, just feedback, comments, because that's going to be really important with regards to how we build the next one. Chris, Maria, are you happy if I start going through some questions?
Absolutely.
Maria, I'll start with you, and Chris, please sort of interject if you want to add anything. The first question here is, the model is really exciting. How do you feel it will help clinicians in clinical practice?
I think we're really busy in the clinical practice. We can't actually take the time to go in often now into an auditorium setting because we just don't have the capacity in our workload. So I think having this visual, almost fun, modern, dare I say, teaching aid will be able to be used in all elements of our clinical practice. We can actually show it to our patients as well to get them to have some understanding of venous leg ulceration and actually what does compression do and how this can benefit. It's really important for newly qualified staff maybe, or staff that you're having new into your department, and it's a really fun way of just teaching in a different way. So yeah, really positive and definitely the way forward.
And I would like to say that from a really practical point of view, it's a good way to get people trained in how to apply compression properly, which is very commonly the issue. Oh, we're not trained, therefore we can't apply it. And if you can't apply it, you're not going to get anywhere with the wound healing. So first of all, it can allow people to see how to apply it on a mass concept here. It's going to reach a very wide audience. So that's fantastic. But not only doing the application, but putting it in the perspective of the patient as a person, understanding that they do have barriers and challenges and they may be reluctant, but the reluctance is coming from a place that we need to address. And we know that if we don't treat the cause of the venous insufficiency, if we don't apply compression, whatever other dressing or treatment that we put on there, it simply isn't going to work to heal the wound because we haven't treated the cause. And patients need to understand this because very frequently I find patients think it's the next dressing. Well, it's the wrong dressing. So that's why I'm not healing. It's the wrong dressing. So this really clearly illustrates to new providers, clinicians that may be not very familiar with venous insufficiency and compression, that this is a critical component of care, but we have to put it in a format that the patient can accept and having dealt with their barriers.
Thank you, guys. Maria, do you want to add to that, or do you mind?
Sorry, I was just going to say, and from a clinician point of view, it's just so easy to apply. And you can actually mold it around the limb as well, and the less slippage. There's no concerns about looking at different shapes to get them the right side. Full stretch is the correct way to apply it. So really easy to apply for a clinician, and the module will help to teach that.
Well, look, that leads on perfectly to our next question, which is portrait of a patient incorporates training for the use of Coban 2. Can you explain your experiences using 2-layer compression in your own practice and how it's helped you and your patients? Chris, do you want to start with that one?
Sure. So I can remember before this system came along, it would be more layers you would have to apply frequently. So that takes more time and it's more complicated and it's hotter and it tends to slip frequently. And there were multiple different options and all of them have the same issues. So this is so much easier. It's very, very quick to apply. It doesn't slip. It stays in place. And the patients tolerate it extremely well. So this has really improved our practice. And it's doable for us and it's doable for our home care nurses.
Brilliant. Thank you. Maria, do you want to add to that?
Yeah, absolutely. You know, certainly when I began my career, undertaking compression bandaging, the multi-layer, it was trying to work out which was spiral, which went figure of 8. It was almost like a nervous breakdown, to be honest. But with the Coban 2, it's easy application, really easy to do, easy to follow, and patients are really happy and comfortable in the product. And the thing for me is that they can actually wear their own footwear. I had a patient when I was working in the community who was desperate to go to her daughter's wedding, but felt that all the bulkiness and the dressings may leak, and she was really concerned. So she wasn't really convinced that my suggestion of the Coban 2 was going to work, but I assured her that it would stay in place, that she could wear, you know, a decent sandal that was gonna match her outfit, and she made it to the wedding with her decent footwear, and she was really pleased with the product and continued with it, and they also went on to heal. So it's all really positive.
Fantastic. Chris, in fact, Maria, I'll start with you on the next one. Does the second layer have to be applied at full stretch? And what if it isn't?
Yes, it does need to be applied at full stretch. And I think, again, it's really important that the practitioners apply it consistently. We really need to be moving away from you know, patients will say it's maybe a bit tight or a bit firm, but it's explained to the patient, engaging with the patient and ensuring the product is applied correctly. It's that consistent approach to practice to make sure we heal these ulcers. And again, that's down to training. We need to train our nurses and practitioners, ensuring the application is applied appropriately. But again, you know, using the great giraffe and the flamingo analogy and the portrait of a patient is a brilliant, innovative way of learning, other than, you know, chalk and talk, potentially with previous presentations. So it's really positive.
Chris?
Yeah, and I would say what I would add to that is that often patients, when they start, may be a bit reluctant, or they might be trying to talk you into a lighter type of compression because they think it's more comfortable. And even sometimes clinicians will say, well, I'll start on something light, so because it's going to be more comfortable. But if it's inadequate compression, will not get you to healing. So assuming that their vascular perfusion is within range, you want to go to full compression to get the results. And the first little bit, that when they start wearing it, it can be more uncomfortable because there's a lot of edema and swelling that is being pushed against. But you can do things like elevate their limbs and so on to make sure they're putting it on first thing in the morning before their feet hit the floor. If that's the thing, like arrange for an early morning visit. You need to do it when the edema is down so they can tolerate it. But know that, you know, once you get that edema under control, actually it's going to become much more comfortable. So I often tell patients it's an over the hump thing. We need to get this fluid out of there. And at first, the first week or two, it may be a little bit more uncomfortable, but we can deal with pain management. We can deal with other strategies like elevation and so on to get used to the idea, because this is the only way you're going to heal. And what will happen is patients come back to the clinic, you know, in a few weeks, and also they've had for months has suddenly healed because they've given enough compression. So, you know, patients are not always informed of the risk of not doing this. They're often told, oh, well, we'll just put you in this more comfortable system, without thought that this may keep them with an open wound for months or years even. So we're not really doing them any favors by not informing them fully.
Thank you.
Sorry, Ed, can I just add that it's so essential. So in my clinical practice, if you start someone on a below therapeutic dose of compression, although they are suitable, is what Chris says, you know what, it's so hard to get them to that full therapeutic dose. We really must start our patients at the right therapeutic level of compression, and we need to change the language. We need to be talking about healing these leg ulcers, not opposed to managing them, which is really important. Changing that language in our clinical practice is so essential.
Yeah, agreed 100%. Too often you hear healthcare professionals say they never use the word healing. And that's I think it's key to a lot of the content we're putting out at the moment. So question 4, Chris, I'll start with you. If the patient wants to remove their bandaging for a break in treatment, what would you advise, and is this okay?
So I would discourage them, because again, without the compression, we're not going to put the limb in an environment where healing is going to occur. So again, this is another time to have a conversation with them about what's going on, what are the barriers, what are the issues, and to sort through that. And I will say, again, this speaks to the last point too. We have little bracelets in our clinic that says compression on, wound be gone. And that's the message we tell them. You need to be wearing the compression if you want your wound to be gone. That's it. Compression on, wound be gone. Otherwise, maybe you're not aiming at healing. So what are your goals? Because we may be a maintenance situation then.
Maria?
Yeah, I think from my perspective, totally agree with Chris. Then a break in compression isn't a good idea. The edema will return, the exudate will increase. We'll be going backwards as opposed to forwards. And I guess in some ways it is trying to understand the rationale of why the patient does want to stop the therapy. Has the pain increased? Is there maybe not a suitable dressing underneath the compression being used? So for me, I'd be trying to get to the root cause of why the patient wants to change the plan of action. But if it could be pain, so let's address the pain. What is really the reason, and really discouraged, because things will deteriorate, and then we'll almost be back to part one of the process, which we don't want. I love the great idea, Chris, of the bracelets. I might be pinching that one.
Okay, next question. How often does ABPI need repeating? Maria, do you want to start with that?
Yeah, so we actually undertake it a minimum 6 monthly. So to make sure the actual compression is still suitable. Obviously, if there's any sudden deterioration in a limb, we would undertake it sooner, any increased pain, etc. But usually 6 monthly.
And I would say it depends on your local protocols. And I think 6 monthly sounds like a reasonable protocol that many home care agencies would have. I work in a hospital setting with vascular surgeons. So just a note that we don't necessarily need that particular test. If they've done a CT and they've just done an angioplasty and they've got all the beautiful images, or they've done thorough Dopplers and that kind of thing, a vascular surgeon assessment will trump a local test. So because they have much clearer imaging. So all of our patients are thoroughly assessed on admission, and if they're improving in our clinic, we're following them. They're usually on surveillance after they've had a revascularization. Usually about every 6 months would be sort of within range for vascular assessment.
Thank you. Maria, do you want to add to that?
Again, I think as Chris rightly says, it depends on your setting. I'm also now in a vascular smart centre, so we've got all the experts very much to hand, with far more higher tech equipment than I had in the community. So it does depend on where your actual clinical setting is. But I think the key thing is listen to the patient, look at the symptoms, look at the wound, measure your wounds, look at your decent wound assessment, documentation, and if there are any changes, then absolutely reassess sooner.
And I would say too that if the wound is healing and everything's going swimmingly, the chances are that you're within range as far as perfusion goes, because that's not going to happen. I would say conversely, if you're starting to see a lot of new infections and new complications, you wouldn't wait 6 months necessarily. If you're starting to see anything go the wrong direction, then you would also do a vascular assessment.
Absolutely.
Thanks, guys. So the next question was actually asked by loads and loads. How effective is it in wounds with high levels of exudate?
I'm happy to take that one, Chris, first, if
Go
that's
ahead,
okay.
You go ahead. You go ahead first, and then yeah, I'll.
It's really effective, but it's what you use underneath it. So I found really good results with Keramax Care, also made by Solventum that make Coban 2. It is really important we manage that exudate effectively. So really good products, but not every wound obviously needs a super absorbent underneath it. So again, manages really well as long as it's applied appropriately. The foam layer is really useful as well, and very different to obviously products we've used previously. And manages exudate perfectly, because you actually just go up the leg with the foam, and obviously you go up the leg with the Coban as well. So, and it molds and sticks to it sticks to itself. So really useful.
And I would add to that, so where's the fluid coming from, right? So where is it's coming oftentimes from unmanaged edema is a good portion of where that's coming from. So what happens is you get this all unmanaged edema because they haven't been wearing compression or enough compression, and you get all this fluid there. And then because you've got all this fluid there, well, bacteria that like fluid are Pseudomonas. So you tend to get these Pseudomonas infections, and then the skin starts to deteriorate and gets all macerated and so on. The key is to switch off the tap. It's to cut off the fluid exudate. And the way to do that, again, is compression, and then manage any infection that comes. But the key is to cut off the tap, and compression is a key way to do that.
And can I just add, Chris, as well, I'm really an advocate that we cleanse wounds, we don't anoint them.
Oh, yes.
With that, I mean, a sprinkle of saline is not going to do it with a leg. We really need to, soak that leg, debride all that dead skin, and use a really good emollient. It's really important we actually cleanse and don't anoint.
You need to clean with intent, and you need to use a cleanser ideally to improve that situation completely, because you want to reduce the number of bacteria there. And the other thing is for the drainage is that you want to be downgrading those dressings to something thinner as soon as you can manage it, because compression works by pushing against if you have like thick dressings, layers and layers of wrap and all kinds of other stuff underneath, the compression is actually not compressing on the leg too much. So the more layers you put under there to sop up that drainage, the wetter things often will get. You need to slim that down so the compression can work better, because again, to turn off the tap, you need the compression.
I'm loving the anointment of the wound. I made me smile. So next question, Chris, I'll start with you. Can you double the last layer of Coban compression for full compression?
You're in full compression if you apply it properly. You're not doubling it or making it more so. And remember, we're trying to make sure we apply compression safely. What we don't want to do is put too much Coban on there and perhaps have a sort of tourniquet effect. And certainly with people who are just on the edge of 0.8 and above. So I would say no. You apply it as it's meant to be applied.
I totally agree, Chris. And again, going back to, we need to keep this low profile. That's the beauty of the product. Get the footwear on, and going against manufacturers' instructions, I certainly wouldn't advocate. There's always lots of instructions in the relevant product box, so absolutely not. And certainly keep it low profile.
Thank you, guys. So Maria, for you, does Coban 2 come in different colors? Male patients ask for different colors.
Not that I know of, no. Certainly in the UK it doesn't. But what I've done in the past, obviously, some patients haven't preferred we have obviously different skin tones as well. That's really important. But I've often used asked patients just to pop their socks over, their normal socks, so they can't see under their trousers if they've got them under trousers. So that's really worked effectively. ladies will wear their tights over as well, sometimes coloured tights. So yeah, I guess, you know, in the perfect world, we'd have lots of colours of every dressing and product, but with our strapped cash strap budgets that we're all working under and formulary constrictions, I guess unfortunately we can't do that.
Yeah, and it's the same over here in Canada. It only comes in the one flesh tone color, and then it comes with a black sock. And I will say that female patients too will often say, why is it a black sock? I've got it on one leg. Why is it not like flesh colored so that it, you know, we don't understand why don't they have the option? And I think that's the company choice. You know, that's totally up to them. I will say when we do total contact casting, we have all kinds of different colors we can offer people. They've got hot pink and red and black. Sometimes people will be wound in the colors of our hockey team here, which is the Senators are red and black. So, you know, it's nice to do that kind of thing if you can, but the reality of the situation is that, again, we can't afford to have all these different colors. It's not available yet, but you can certainly give that feedback to Solventum.
I think as well, it potentially could cause confusion for clinicians applying different colors, and they might think it's a different level of compression. So no, I think we have to stick potentially with what we've got. And you know what? It works really effectively. We just need to work around it.
I would say though that just to be devil's advocate on this one, I agree with that. I totally agree with that. But maybe if it were hot pink or something, it looked cool, or it was like an army print or something like that, some people would think it was cooler to wear. I don't know. Who knows?
Thank you, guys. So next one, Maria, I'll start with you. A patient has had a recent heart attack. What's your guidance around compression?
It obviously depends on, you know, they'll be under obviously the relevant medical, so we need to discuss with the consultant and get some advice on the patient's overall comorbidities. But certainly we need to address venous leg ulceration as long as the consultant's happy for the management of the patient, and a full leg ulcer assessment is undertaken. We've got the ankle brachial pressure index in line with your relevant policies in no matter what clinical area you work in, and there's no issue as long as actually it's all managed and documented accordingly, and you've got that buy-in from obviously your medics that are looking after the patient.
Thank you.
I would agree. It depends, right? As many things, it depends on the patient. So you would absolutely talk to the consultant in charge of the case to make sure and document that it is safe to apply. But as I always tell patients, you know, the heart and lung trumps the leg. So if putting compression on is going to put your heart into some degree of overload, pushing that fluid up into the central area, or if it's going to make you short of breath, you know, the heart and lungs always come first. So in that situation, if you're thinking it's, you know, contributing to, you know, cardiac stress or respiratory stress in any way, you can cut it off and just have an assessment and then resume. That's the very safest way to do that.
Guys, thank you. We've got 2 more to go. The questions are flooding in, but we've run out of time. So Chris, I'll start with you. Does Coban 2 layer compression system have latex?
No, it does not have latex. It is completely latex free. And this is critical actually in our hospitals here. Well, certainly the hospital I work in, I think most hospitals in Canada, you have a hard time getting any latex product in unless there's no other option. All of our equipment, everything, we've gone latex free because such a serious allergy. There is no latex in Coban 2.
Thank you. Guys, last question, which I think I can actually answer. The question is, if you complete the modules, will you get a certificate at the end? The answer is absolutely yes. The modules have a certificate which you can download, but also a whole comment and feedback section as well. So do the module, you get the certificate. There's a Q&A as well, but then please give us the feedback at the end. Guys, so that's the end of the questions. Thank you so much for your presentation, but also for the honesty and expertise around those questions. I know it was massively appreciated. I'm staring now at all the comments, questions, and kindness that's coming through. So if you get a chance, please watch this tomorrow, because I think you'll love what you see. Guys, the link for the certificate of attendance should be made available right now. That counts towards revalidation in the UK, so download it and put that in your portfolio of learning. As I said, the slides and the event will be available on our website at Wound Care today, woundcare-today. So you can download those, share them with your colleagues. If you want to meet the Portrait of a Patient team, we'll be at the Wound Care Today event in March in Telford to sort of help explain why we've done it, to take you through the content and to bring alive the animation. So a massive thank you from me to our speakers. Chris, Maria, I know the hard work you put into this, so thank you so much. Much appreciated from me and the team. To everyone at Solventum, as I said before, your passion for compression and your commitment to this education means a great deal, and this doesn't happen without you. To wound care people, to Mole, and mainly to Get Animated, who've spent the last year putting together this animation, just thank you so much. Last but not least, to the people watching tonight, thank you for your hard work. You continue to humble us. Stay safe, stay strong. So ladies and gentlemen, please go to portraitofapatient.com, do the module, and let us know what you think. Have a very, very good evening, and we'll see you here very soon. Thank you so much.
Thanks, everyone.